In today's video, we're going to be talking about PSA rise after treatment. There are different types of treatment, and there's also active surveillance and the monitoring of prostate cancer. And we're going to talk about what would signal a significant enough rise that treatment or further investigation needs to take place. So today we're going to talk to Dr. Mark Scholes. He's a 30-year medical oncologist who's focused solely in prostate cancer, and get his opinion on what would be a significant PSA rise. So when you're saying a sequential significant rise, over maybe what time frame and above that 0.1 status, let's say there is prostate tissue that is left over, would you say if it's 2 or if it's 3, we need to look at it?
Well, the surgeons like to say if the PSA is above 0.2, people like to simplify things in generalities to give a context, not to suggest that that threshold is always going to be 100% useful or accurate. PSA above 0.2 is thought to be a cancer relapse rather than residual prostate tissue. You can detect cancer relapses far below 0.2 if you're using an ultrasensitive assay. Some of these assays go down to 0.003. Let's say you're checking the PSA monthly and it goes from 0.003 to 0.005 to 0.09 to 0.011, and you have a sequence of growth, steady, unremitting, consistent rise. You know that you're dealing with cancer even when the PSA is less than 0.2.
Moving on to radiation, we do have radiation working differently than surgery because once the tissue in the prostate is radiated, the cancer in the tissue in the prostate is dying slowly over time. With surgery, we see an immediate PSA drop. With radiation, we don't see that drop as, it takes a much longer amount of time. So in reality, when it comes to radiation, a lot of patients struggle with this question a little bit of which one to get because they want to make sure that the treatment is working. So can you talk about what we should see as a PSA nadir, that final PSA number once radiation has taken its time for that PSA to drop?
Let's just take low-dose rate seed implants, for example. The early work that was done by Drs. Blasko and Grimm up in Seattle at the Swedish Cancer Institute, starting back in the 1990s, they reported that from the time that the seed implant was performed, which is a one-day implantation of radioactive seeds to destroy both the cancer and the prostate, the interval of time from treatment to when the PSA hits its very lowest point and stays there, so-called PSA nadir, is 30 months. Median means that half of the men got their PSA to that low point, which could be anywhere from 0.02 to 0.2 or 0.3. Half of the men took less than 30 months to arrive at that nadir, and the other half took more than 30 months to arrive at that nadir. These are people that were followed for many years and were deemed cured over a long period of time, but the time to get to their PSA low point on average, or the median is the more precise term, was 30 months. So it's a very slow process for PSA to decline. This is not always realized because many men that are doing types of radiation are also taking hormonal therapy, and hormonal therapy will cause a sharp decline in PSA. When men are getting hormone therapy alone, the average time to nadir, the low point of the PSA, is probably around 4 to 5 months, 3 to 4 months, 5 months, something of that nature. So since hormone therapy and radiation are often given at the same time, you'll see PSAs decline more sharply. But when you give radiation as a standalone, the median time was 30 months.
Before I get to my next question, I just wanted to remind you to click that subscribe button. It's a great way to support our channel. Also, if you would like to support us financially, you can do so at pcri.org/donate. And we have an in-person conference coming up in September, and you can find out more at pcri.org/conference. Now back to my conversation with Dr. Scholes. Is the marker then with radiation that we're just seeing the PSA continue to decline? It's not going up, and then that means, yes, you are in that process where the radiation is working and the cancer cells are dying?
Well, that's the way it's supposed to function. There is a phenomena called the PSA bump or bounce, where men seem to be going along great for, let's say, a year or two. Their PSA is steadily floating down like a leaf on a calm day. And all of a sudden it jumps up, which creates concern that maybe cancer is back. But we know that there's a common phenomenon of delayed radiation prostatitis that can occur 1 to 5 years after the seed implant. And this can elevate PSAs transiently for a month or two, or sometimes elevate PSAs for a more extended period, over a year. And with no intervention whatsoever, mere patience, then the PSA will sort of zigzag around, then start going down again and head on back down toward the nadir. So there can be confusion along the way in this process of PSA decline, complicated by this delayed radiation prostatitis phenomena. Probably occurs in maybe 1/4 or 1/3 of men that have seed implants.
A couple quick questions on the bump. Like, what type of jump are we seeing? Are we seeing it goes from, a couple points, 10 points? What does that look like?
Well, the most dramatic bump that I encountered in a man with very low-grade cancer, we almost knew that he couldn't have metastatic disease, was an implant where the PSA was maybe 5 or 6 when he had the treatment, and the PSA quickly rose up to 15 within 6 months after the implant, and stayed there for 2 years before, bouncing around 16, 15, 18, 12, 16, 15, before it finally went down. This implant was done 20 years ago, and he's had a steady PSA of less than 0.02 for over 10 years now. He had no treatment. We simply waited it out. So that's extreme. Technically, you can see bumps where someone's PSA has dropped down to 0.4 and it goes up to 0.5, 0.6, and then goes back down to 0.3 within 30 to 60 days. So they can be very, actually so small that maybe people might not even notice them.
So after somebody's reached this PSA nadir, and it can be, as you said, this, 0.2, 0.3, as you've mentioned, what do we consider a significant enough rise where we're going to say, first of all, what's the duration of time that it's been there? And then what do we consider a PSA rise in that situation that would cause somebody to say, we need to take a look at this?
In the old days, when they were doing clinical research, the radiation therapist said that the PSA had to jump 2 full points. So let's say your nadir was 0.3. So they wouldn't declare a cancer relapse until the PSA rose to 2.3, 2 points above the nadir. And this was done for uniformity to define success rates for radiation. And these were the methods that were used in academia for publishing studies. The reason for that big 2-point interval is because of bumps. They wanted to eliminate most of the bumps so that they wouldn't construe bumps as relapses. But the development now of PSMA PET scans, I think, kind of renders that mentality ridiculous. Well, we would never wait for the PSA to get up to 2.3 to do a PSMA PET scan. We know that PSMA PET scans can show where cancer is, sometimes with PSAs as low as 0.2. For that reason, when we run into bumps these days, we'll almost always do a PSMA PET scan to ensure that it really is a bump. It would be kind of sad to pat someone on the back, tell them that they have a bump, and although statistically it's probably more likely that they have a bump, there's still a possibility of cancer relapse. These now can be detected with PSMA PET scans. So I would say if someone's hit a nice nadir of 0.1, 0.2 and been holding in that range, and now it goes up to 0.3, 0.4, I would get a PSMA PET scan and look into it. Bumps are not common after more than 5 years after a seed implant. So someone that has a rise in PSA that's beyond 5 years from treatment is more likely to be a relapse. I think it's still possible to have bumps after 5 years, but scans make it easy to sort that out. We don't have the same dependency on trying to parse out all the statistics and probabilities when you can simply get a scan.
So what about in situations where you never really reach that PSA nadir?
Right, and that's where, again, you're trying to determine, is the slow decline in PSA a concern, or if you've got someone who's had their PSA decline somewhat after treatment and it starts to rise, but not in a zigzag inflammatory pattern that we see with bumps, but where it looks like a smooth, steady upward trend where each PSA is always somewhat higher than the last. That's more characteristic of cancer failure or cancer growth. And of course, that should trigger a PSMA PET scan to find out if there's untreated cancer somewhere in the body.
The type of radiation that we've been talking about is seed implant, as you've mentioned, but does the PSA and that decline work in the same fashion with, beam radiations, protons? Does it vary a lot, or are all radiations kind of the same as far as this PSA decline?
They all have slow declines, and I would say that in my experience, it's more common to see men who are getting seed implant radiation without hormone treatment, and we observe this more languid decline. Doctors who are giving beam radiation frequently like to accompany it with hormonal therapy, and that causes a much more precipitous decline in PSA. And so you don't really start seeing the impact of the radiation alone on the PSA until the hormone therapy stopped, the testosterone recovers, and now the PSA becomes interpretable again, after testosterone recovery.
So moving on to hormone therapy, you talked about that sharp decline that we see the PSA do once hormone therapy has started. What is that time frame? And again, what do we consider a PSA nadir?
People, are always impressed by how quickly PSA declines after hormonal treatment. A medicine that makes cancer disappear this quickly, it's rather surprising. It's unfortunately only the case for prostate, but for prostate it works extremely well. Metrics that I think, in my mind from looking at this for a long time, is if someone is starting on hormone treatment, say on July 1st, a month later, after a month of treatment, we expect the PSA to, on average, decline about 90%. So if someone's PSA was 10 when they started their hormonal therapy, it should be around 1 at 1 month out, and it should get down to less than 0.1 within 5 months. So you see a sharp decline and then slower decline over the ensuing months.
We actually see a lot of patients on Helpline where they're on hormone therapy and they start to get this PSA rise, and sometimes we don't see maybe their medical teams taking a quick enough action. We see sometimes that their PSAs are going up to 1 or 2. This tends to happen in more community centers and local centers versus large universities. So can you address really what you would consider a PSA rise with hormone therapy patients?
Well, even a failure to decline, not a PSA rise, but failure to decline is a real concern about the possibility of hormone resistance. So you can get, the lab guy can have a bad day at work one day and you get a screwball number. Whenever PSAs are not sequentially declining on hormonal therapy, and typically we're checking PSA monthly when people initiate hormone treatment, any failure to decline is a big concern. Now, that can happen. You can get an errant number now and then. You check the PSA again the following month and it continues declining. Great. But there should be a steady sequence of PSA decline right down to we call it undetectable nadir, or a PSA less than 0.1, maybe out to 8 months afterwards. If you're getting 8-9 months out and the PSA still is not below 0.1, that's a sign of hormone resistance.
Once you're at 0.1, though, let's say you've been on hormone therapy for quite some time, at what point would you say it's at 0.2? Is that too far? Like, how quickly should we be moving? Because hormone resistance is just such a different animal when it comes to prostate cancer in comparison to other treatments. This type of a relapse is something that needs to be taken seriously because that's kind of the best tool in the arsenal, as they say.
The hormone therapy is, one could argue, is the best tool, and if it's not working, that's a very, very concerning development. The situation with PSA, I would counsel people when they're looking at monitoring after some sort of treatment, is to not only look at the threshold or the number, but even more importantly, look at the trend. PSA, if necessary, can be done every 2 weeks. The indicator of the presence of cancer, uncontrolled cancer, is that it's growing, and if it's growing, the PSA will continue rising. Studies have also shown that how quickly it rises is also an indicator about the type of cancer and how serious it is. So having more data points in a situation where there's uncertainty, the PSA isn't as low as it should be, there's questions of it rising, don't tell the patient to come back in 3 months or 6 months. If your last PSA raised questions, let's start checking the PSA every month for a while to see if this is just bad lab assays and everything quiets down on its own. Great. Or is there a sequential unremitting rise? That situation is 100% accurate for concluding we're dealing with prostate cancer.
One of the terms that we see come up often is PSA doubling time. Can you define what PSA doubling time is for the audience, and in what situations we need to pay really a lot more attention to it?
Sometimes it's overapplied. There are 2 situations where it's useful, maybe not as useful as it used to be in the era when we didn't have PSMA PET scans to find out where the cancer was. But in particular after surgery, they've shown that if you're doubling time, that is, let's say the PSA is 0.1 and it takes a year to go to 0.2 and it takes a year after that to go to 0.4, you've got a doubling time of 12 months, and that's a very indolent type of prostate cancer. If the PSA is at 0.1 and it goes to 0.2 in 3 months and then to 0.4 in 6 months, you've got a doubling time of 3 months, and that's a more aggressive type of prostate cancer. So this is very useful because the prostate gland has been removed. There's no possibility of PSA bumps. There's no inflammatory issues going on with the prostate. So it's a quite useful indicator of to how serious the cancer is in that particular individual. Doubling time, probably the second most powerful thing after the PSMA PET scan in ascertaining how serious the situation is. Not the Gleason score, it's the doubling time. Utility of doubling times in people on active surveillance or people that have had previous radiation, it's almost useless because there's so much background noise from the prostate. People that have had radiation in the doubling time, because oftentimes the prostate has been put to rest with the radiation, can be useful. Doubling times in men that have advanced metastatic disease, say they've become hormone resistant, they have bone metastasis, they're getting chemotherapy. There is certainly greater urgency in people that have doubling times of 1 month versus doubling times of 6 months. So I would say the two places where doubling time are most relevant are after surgery, sometimes after radiation, when the PSAs are low before you can get a PSMA PET scan. It may give you some sense of how relevant the cancer is. And then in people with very advanced disease, hormone-resistant disease that are on chemotherapy, if their doubling time is quicker, then you know that you need to switch to other effective medicines as quickly as possible.
Now, going on to active surveillance. So, this is Gleason 3+3, Gleason 6 prostate cancer. It's 50% of prostate cancers that are diagnosed. A lot of men are getting these treated. It does not need to be treated because it doesn't metastasize. If prostate cancer does come, it's a different tumor. And so I like to put that context at play when we're talking about it because I think it's helpful for the audience to understand. But as far as, active surveillance goes, this is a struggle for active surveillance patients because they do have their prostate, they have never been treated, they have this PSA that fluctuates quite greatly at times, and because they have the prostate, they're dealing with BPH or prostatitis at times, so inflammation or an infection. And so there's a lot of noise that PSA is making. So a lot of men are wondering, how do I use PSA? Can you even use PSA to monitor whether or not to get treatment with, active surveillance because the numbers fluctuate so much? So what would a scenario look like in that case?
Well, for our patients on active surveillance, we're getting PSAs twice a year, every 6 months. We're getting an MRI once a year at a good quality center and comparing it to the MRI from the previous year to see if there's any new spots, any enlargement in some of the old spots, whether that's stable or not. It's really the MRI that we rely upon almost exclusively, not PSA, for determining if someone's cancer is misbehaving. And one could even ask, why do we even do PSA testing? Because we know that there's all this background noise, and a number of studies show that PSA is a poor indicator of whether the cancer is getting worse or not in the prostate. I mean, when you look at using PSA to judge how bad a newly diagnosed cancer is, we use increments of 10. 1 to 10 is low risk, 11 to 20 is intermediate risk, and 21 and above. So you're talking about huge amounts of PSA change for the doctors to even acknowledge that it makes a difference. Again, circling back, why are we doing PSA testing in our active surveillance patients? Are we just creating a lot of unnecessary anxiety when we're going to do an MRI anyway? And the answer is that there are very rare, I've seen less than 10 cases in my whole career, of cancers that can not behave like prostate cancer. They come from the prostate. They should probably have a name of their own. They're very, very rare. But they can grow so quickly where a man who was screened for prostate cancer last year and his PSA was 3, and he gets screened on a routine basis 12 months later and his PSA is 60. I'm always shocked by these things, and I'm in the prostate world all the time. This is so uncommon. But imagine how terrible it would look if one of those new cases, these people get a brand new cancer. We're watching them with a low-grade process that we know is not going to change. But we're really watching these patients because of the possibility of another new higher-grade cancer showing up in the interim while they're on there watching. And we want to detect that at an early curable stage. So we'd have a lot of egg on our face if we just slapped people on the back and told them, we're just going to do MRIs, and then they come back next year with a PSA of 60. Inexcusable. It's very easy to check a PSA during the year. But we don't track the PSA went from 4 to 7, Dr. Scholes, or it went from 3 to 6. We see this sort of variation all the time. We do counsel people, no sexual activity the day before. Don't ride your racing bike for a couple days before your PSA testing. But even with all the fastidious attention to detail and proper behavior, PSAs still jump around a lot. A couple 3 points either way is common. You can run tests on people where you check their PSA in the morning and it's 2, and in the afternoon it's 3. 50% rise above baseline. This is horrific. This is terrifying. No, this is just the way PSA moves around.
A couple of key things that we talked about in the video that I think would be a good reminder for you as you see these PSA fluctuations. Number one, as Dr. Scholes said, Labs can have variances, and so you want to maybe get a PSA double checked if you do see a rise or if anything errant comes up. You just want to make sure that the information that you have is solid as you go ahead and make decisions off of that. The second thing is to, again, look at trends. It's important to track your PSA, write it down, whether you have it in a journal or Word document. Some patients actually track it on an app and they find this quite helpful. And you could even log into your medical records and make sure that you have your medical records through your chart and see what your PSA has been doing over time. This can give patients a lot of just peace sometimes that maybe the PSA does jump around, or give them information that is actionable that they need to talk to their doctor. Now, if you do see that there is a trend maybe of PSA increase, and then you also see that the second lab that came back, does confirm that that number is rising, it's important that as you go through this process, you remember that you do have time to look at the treatments, you're catching it early, you're being really on top of, checking your PSA and making sure that you know what these numbers are. And that even in those situations that you do have time, and luckily in prostate cancer, there are a lot of treatments that doctors have in their toolbox to help, work through this situation, even in situations where hormone therapy may no longer be working. Now, if you need help with your particular case and you just have some questions maybe about PSA, you can contact our helpline at pcri.org/helpline. They can even help you just look at the PSA information, the report, and they can tell you, oh, this is an ultra-sensitive PSA, this isn't, and talk to you kind of about the variances that you may see in your PSA. The whole point of the helpline is to help you not only get information, but also kind of give you some peace of mind as you go talk to your doctors and your medical team and bring up, your concerns and what your thoughts are through this whole process. Please remember, most of all, you're not alone, and I hope you have a great week.